Hello and welcome to the Endometriosis and Pain Management webinar. So we are joined today by our guest speaker, Dr. Lucy Whitaker, who will be introducing herself in just a moment. Before I hand over to Lucy, I would like to remind viewers that this webinar is an hour long and we'll have a Q&A section at the end where Lucy will be answering live and pre-submitted questions on pain management and endometriosis. For any individualised medical guidance, please reach out to your healthcare provider. I'd also like to make viewers aware of potential trigger warnings during this webinar. So please be advised that this webinar will contain images of surgical procedures and viewer discretion is advised. However, there'll be a tiny blue asterisk at the bottom of the screen prior to the slide letting you know when these images are coming up. So without any further ado, I shall pass on to Lucy.
Thank you very much, Sophie. Hello everyone, my name is Lucy Whitaker. I'm Senior Clinical Research Fellow at the University of Edinburgh and I also work at NHS Lothian. I'm a consultant gynaecologist as part of our endometriosis centre there. I'm an academic, so I've got a few disclosures just in terms of the funding that I've received for some of my research, most of which is from national bodies. And I've been a consultant in Edinburgh since 2023, having done the advanced laparoscopy training for endometriosis care there. Throughout this presentation, I am going to use the word woman and women, but recognise that endometriosis, menopause and pain can affect all those assigned female at birth. And as Sophie said, I'm also going to have got a few pictures of endometriosis surgery, really just to illustrate differences between subtypes. And before those come up, there'll be a little blue asterisk like that in the right-hand corner. So as I said, I'm based in Edinburgh and our endometriosis centre there is something called EXPECT, which is a collaboration between the University of Edinburgh and NHS Lothian. And it's our BSG centre for South East Scotland. We're the second centre in Scotland after Aberdeen. We do a lot of research, predominantly in translational research into endometriosis, so that's clinical trials. But one of the things that's more pertinent for this evening is that we were the first, and in fact, we're still the only multidisciplinary, specifically pelvic pain clinic in Scotland. And we've got a lot of information online, and this is our website here, and I'll give the link at the end. But I'm going to spend the next sort of 35, 40 minutes or so telling you a little bit more about what we do, how that might be useful for you and some ways in which to access that type of care more locally where you are. Although, as I'll talk about later on, there is a lot of differences between different trusts about what individuals can access, but I want to talk more broadly about some of the aspects of multidisciplinary pain management. And so we'll go through, I want to start by just doing a little bit about mechanisms of pain, because these are quite important concepts of why some of these different approaches can be really helpful. And we'll take questions at the end. So first of all, I think one of the things that has really held us back in endometriosis, both in terms of diagnosis, better treatments, better care, is that we've thought of it as this one single condition. And I think we're all much more aware now that there are three distinct subtypes. So you've got superficial peritoneal endometriosis, ovarian endometriosis or endometrioma or chocolate cysts, as sometimes called. And then there's also deep endometriosis, which is these nodules of endometriosis, so anything more than 5 millimeters deep. And that's often the type of disease that sits between the uterus and the bowel. Now, these subtypes have probably all got different natural histories, so how they kind of progress over time. They probably respond to medications differently. Certainly deep endometriosis has got much more fibrosis, much more scarring, so it's perhaps sometimes a little bit less hormonally responsive. And certainly the subtype of endometriosis has implications for both the response to a surgery and also that risk of surgery. So I think it's really important to think of these contexts when we're thinking about some of the endometriosis specific treatments. I think one of the other challenges is that there's lots of different symptoms with endometriosis, and different individuals might have completely different symptoms, or they might have lots of the same symptoms, but the impact of those different symptoms might vary between different individuals. And then what makes things even more challenging is that we have this disconnect between the symptoms and the subtype and extent of endometriosis, which adds additional challenges into disease that we still don't fully understand the cause and we don't know the natural history. But what we're going to focus on this evening is pain management. So that's pelvic pain, painful periods, pain with sex, bowel and bladder symptoms. And I just wanted to start by a definition of pain. So this, the formal definition is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. And this concept of tissue damage and how we're sort of hardwired to think about that pain equals tissue damage, I think is really important when we start thinking of management of chronic pain. So we're going to come back to a little bit later on. So why does endometriosis cause pain? So this is a superficial peritoneal endometriosis lesion, and we know that these lesions cause a lot of inflammation in the pelvic cavity. So you get this big influx of all these inflammatory blood cells, so what called white blood cells. And these cells release additional inflammatory chemicals, which all contribute to this sort of almost inflammatory soup in the immediate environment. And these activate some of the nerve fibers that we find in the lining of the pelvic cavity and go to the ovaries, go to the uterus and the bowel. And so all this inflammation activates these nerve fibers, which then travel up and meet another nerve fiber in the spine, and that goes up to the brain. And there's two really important pain processing areas in the brain. So that one of them is the thalamus, and one of them is the somatosensory cortex. So you don't need to remember these specific, but there's different areas of the brain that process pain. Now, this inflammation is further exacerbated by, particularly when people are having periods, because menstruation is associated with lots of additional inflammation. So you get lots of release of these other chemicals called prostaglandins. And that's even before the lining of the womb starts to shed. And if someone's got heavy periods as well, this compounds the problem even further, because the uterus has got to contract to push those clots out. The cervix has got to dilate to let them through, and that all contributes to the pain experience. Now, if people have got ovarian endometriosis or deep endometriosis, there are additional mechanisms. So if you've got ovarian endometriosis, there's further pain from that stretching up of the ovarian capsule as that endometrium increases inside. And for those who've got deep endometriosis, that scarring that you've very typically associated with that type of endometriosis, and the nodules are further exacerbated by movement on them. So that things like the passage of the bowel contents going up through those stuck roots of bowels, or something like sex, which inevitably moves around the uterus and then tugs on all that scar tissue. So that can further contribute to the pain. But one of the other really important factors in why does endometriosis cause pain is this concepts of neuropathic pain and cross-sensitization. I know this looks a bit complicated, but just bear with me. So neuropathic or nerve pain is pain that comes from damage to the nerves or the nervous system, or them not really working properly. Like a really good example of that is someone who's got herpes simplex, and so cold sores, and that causes irritation, damage to the nerve fibers, and causes really terrible pain. It's a bit like when you've got shingles as well. Now, in endometriosis, we've got combination of both having a chronic persistent pain. So you've got constant delivery of pain messages, so bombarding those nerve fibers. And this combined with some of the chemicals secreted by those endometriosis lesions make these nerve fibers much, much more excitable. So they start receiving a pain or perceiving a pain signal much, much more easily by things that wouldn't normally be painful. So things like sort of, an example would be wearing tight underwear. That can be sometimes become really irritant and sore. And that's something that should normally be sore. It's because those nerve fibers have become overly irritable. And this inflammation and then this irritation of the nerve fibers is called peripheral sensitization. And what's particularly cruel in endometriosis is that some of the chemicals secreted by endometriosis cause the growth of additional nerve fibers. So not only you've just got your original nerve fibers being really irritated, but you've got these extra ones which also then become irritated. So you've got more and more nerve fibers sending a pain signal up to the brain following fairly minimal stimulation. And this can persist even when the endometriosis has been removed. So you take away this endometriosis, but you've still got all these irritated nerve fibers. And then the problem gets even more because we get this thing called central sensitization. So peripheral sensitization, the peripheral nerve fibers, central sensitization is when the brain starts processing pain message differently. And this is usually as this kind of perpetual bombardment with all these pain messages. And this leads to both increased sensitivity within the brain. So the brain and the spinal cord become much more sensitive to pain signals. And the pain can also become amplified. So that's that normal sensations like light touch or slight pressure can feel really painful. So the pain being out of proportion to the actual stimulus. And then we can start getting widespread pain syndrome. So pain spreading to one of the areas of the body that weren't originally affected. And I think we see this a lot in other areas within the pelvis, particularly the gut and the bladder. And this is called cross-sensitization. And this may be why those with endometriosis are much more likely to develop conditions such as IBS or bladder pain syndrome, so the infamous endobelly. Now, I think talking about IBS and endometriosis is often quite a difficult topic for people, often because a diagnosis of IBS might have delayed them eventually getting their subsequent diagnosis of endometriosis. But I think what's really important is if you've got endometriosis, you're also much more likely to develop IBS as well. And it's because of this cross-sensitization. The uterus also might become more sensitive. Oh, sorry. And there's some evidence suggests that the number of nerve fibers might be increased in people with endometriosis. And we also develop a lot of muscle pain and development of trigger points within those muscles. And that could both be from the sensory nerves to function, but also as a response to pain. So if you imagine you've got a migraine or really bad headache, you often start hunching your shoulders and getting really tense just because as a response to this sort of annoying pain in your head. And the same things happen to our pelvis. If we've got lots of pain down there, we start to have tension in parts, it might be our lower back or our pelvic floor, and over time that those can develop into trigger points. But I've just done a bit of a crash course in pain biology, but I think it's important to appreciate that there are lots of other factors that contribute to pain, including psychological and social factors. And so this is what we call the sort of biopsychosocial model of pain. And it's really important because if we focus purely on the biology, we're not going to be able to manage patient symptoms completely. And that's why I think having a multidisciplinary approach can be really effective. And for pelvic pain, this includes gynecology, pain medicine, psychology, as well as physios and dietitians. And I think also the nurse specialists are really important in this process. So as I said, in Edinburgh, we've got a specific pelvic pain clinic, and that was set up by Andrew Horn. He and I provide the gynecology input, and then as I said, we've got pain medicine, psychology, our nurse specialist, Mia, who is also our endometriosis nurse specialist, as well as our dietitian and physio, Dana and Rona. And our setup in Edinburgh is that patients are referred from secondary care, so it has to be from a gynecologist. So they've already had their workup for initial investigation and first and second line management for their endometriosis. But if people have got ongoing symptoms, they get referred to us if they would like to access the clinic. And we jointly assess them first with the gynecologist, the pain physician, and the psychologist. Now, it might be that beyond that, they then have individual follow-up with one of those three people, or they'll then have further input from our specialist nurse, or the dietitian or physio, or other specialties as required. But we found jointly seeing those three clinicians in the first instance has been really helpful, both for identifying what some of the potential issues might be, having a joined up approach to patient symptoms management, and also really enabling us to address that patient's what the key factors are that are important. And I think also often the patients that we've seen, they've had a very long journey to get us, and they've often felt that bits of their story haven't been heard or that something has been missed. And I think this joint approach is really helpful for ensuring that we don't miss things and we've had fully addressed their agenda. So when we see people at the clinic, before they even come, we get them to fill in some questionnaires looking at part of that's outlining what treatments they've tried in the past, any other medical conditions, what medications they're on, impact on things like sexual function, impact on mental health. But also one of the key factors is trying to identify what does the patient want to get out of this. And I think understanding that agenda is really important, because I think some people, they've felt dismissed with their pain, or they're worried that something's been missed. We also have some patients who come through, one of their underlying anxieties is whether or not there's, perhaps a cancer that's been missed. So we go through the key parts of the history as well. And then in terms of examination, we're often not doing much in terms of a gynecological examination. It's more assessing factors like the pelvic floor, looking for trigger points, and other musculoskeletal dysfunction, as well as assessing for neuropathic pain. So the history can give us some guidance about neuropathic pain, but I think examination can also be very useful. I think we then consider whether or not any further investigations are required. And sometimes this might be an MRI or an ultrasound, but usually patients that we see have already been appropriately worked up from all those investigations aspects. And it would be fairly unusual that we would be doing a laparoscopy to investigate pain at this juncture. So then the other factors of the clinic. So I think it's really important about explanation. And I think some of that bit about pain mechanisms is really important to understand why people are having ongoing pain. And I think also what's a really important feature is disentangling this idea, which we're hardwired to from evolution, that pain equals danger, something's wrong. But we know with chronic pain that actually we don't necessarily have that ongoing tissue damage. It's more those pain messaging processes have all become dysfunctional. And so that needs to be the sort of target for approach. And then it's about coming up with an individualized treatment plan. And I'm going to talk through some of these different factors over the next few slides. So first of all, I think I want to address the endometriosis specific treatment. So that's surgery and hormonal treatment. As I said, the majority of our patients that we've seen have either had multiple surgeries and have got ongoing pain, or are not wishing to pursue surgery, and that's why they've been referred on to us. But I think when a patient does want to pursue surgery, I think it's really important to consider the evidence base. And that's why I talk about, we're thinking about those different subtypes of endometriosis, because we think there is probably a different evidence base to support them between the different subtypes. We tend to have approach that if patients are having multiple surgeries, that if they're going to have further surgery, often we think about whether or not this should be a definitive procedure, such as a hysterectomy. Equally, that needs to be very considered within what that patient's, particularly fertility aspirations, as well as their more generalised wishes are. But I think particularly if patients have got coexisting adenomyosis, so this cousin of endometriosis, when you've got endometrial-like tissue in the muscle layer of the uterus, these patients are a group that do tend to respond quite well to hysterectomy, or if someone's got very heavy periods as well, so that impact on quality of life. So those are the groups that we would perhaps be more likely to offer hysterectomy to. But I think we're more cautious about those doing hysterectomy and those with no evidence of adenomyosis whose endometriosis has previously been completely treated, because often those patients have a high level of neuropathic pain associated with as part of their overall pain presentation. And we know that the more surgery someone has, the more it can exacerbate that underlying neuropathic component. So I think that's the role of surgery is very much about individualized approach. In terms of medical treatment specifically for endometriosis, so one of the big parts of this is hormonal suppression. And many of the patients we will have seen will have already tried multitudes of different hormonal treatments, and they've either been ineffective or had unacceptable side effects for them, or they're not appropriate because they wanted to conceive, or they just don't want to take hormones, which I think all of those are very reasonable stances to have. But equally, if someone's got a cyclical component to their pain, so that by that I mean it gets worse when they have a period, or it's worse around the time of ovulation, then usually having a hormonal treatment as part of a kind of overall pain management package can be really helpful. And certainly in our clinic, we use quite a lot of GnRH agonists and antagonists with ABAC-HRT. And I think what the really important thing is using that HRT, particularly if we're going to use that as a long-term strategy. And I think now that we've got some newer forms of HRT to offer people, particularly bioidentical progesterone, we've had a lot of success of being able to find the right HRT strategy for someone to manage the menopausal component of their symptoms, and then being able to access all the benefits that they get from GnRH agonists for management of their pain. I think it is always about trying to individualize that choice, and sometimes revisiting all the treatments that someone's tried in the past from the different hormonal preparations can be really helpful, because we often don't have we usually don't have a silver bullet for something. There's not going to be one single treatment that's going to fix everything. But understanding the role of hormonal treatment to address that cyclical component, I think, is really important. And then the nice decision age for hormonal treatment can be really helpful in personalising that treatment. But do accept that when these treatments are stopped, then symptoms typically will reoccur. They can have lots of side effects, and they are contraceptive. So in terms of the other medical treatments that are not specifically for endometriosis, so we've got painkillers. So that can be paracetamol, non-steroidals, so that's things like ibuprofen, diclofenac, and naproxen, which I think the non-steroidals are really helpful because we know there's so much inflammation associated with endometriosis. And then the next step on that analgesic ladder is opiates. But I have to say, one of the things we spend a lot of time in the pelvic pain clinic is actually trying to get people off opiates. And that's for a few different reasons. So firstly, if you go and break your leg, an opiate is a great painkiller for acute pain. but we know it's not so effective for chronic pain. And over time, they become less and less effective. So people need higher doses, and there's the issues of addiction. We've all seen the events in the USA with the OxyContin scandal. And we really are trying not to put our patients through that. There's also other factors associated with opiates. So you've got an increased risk of overdose, and this also has an impact on our immunity. And so there is a slight increased risk of cancer with long-term opiate use, as well as all the side effects from them. And I think one of the real challenges for opiates with endometriosis patients is that they're incredibly constipating. And if people have already got that sort of IBS overlay on their endometriosis symptoms, they've got really irritable gut, or they've got lots of scarring and adhesions, which constipation is going to really pull on those, then opiates can be particularly challenging, exacerbating those symptoms. But if we're not going to give people lots of opiates, what else are we going to do them medication-wise to help with their symptoms? And I think this is where the neuromodulators come in. So these are medications that act on that neuropathic pain pathways. So there's a few different types of drugs we use to manage neuropathic pain. And rather like hormones, there's no one that's better than the other. They've just got rather differing side effect profiles. So the three main groups that we consider for neuropathic pain are the tricyclic antidepressants, which were developed as antidepressants, but I have to say no really long used as those. And then the gabapentinoids, that's gabapentin, pregabalin, and the SSRIs and SNRIs, so that's the drugs like duloxetine. Fluoxetine and sertraline are used as antidepressants, but we're also using for their neuropathic component. And I think this relationship between pain processing, mental health is really, really complicated, because particularly we know that over time you get those changes in the brain. And that if we go back to that area called the thalamus that I mentioned earlier on, this is, as well as being really important in pain processing, it's fundamentally important in mood processing as well. So anyone who's got anxiety or low mood or depression will have abnormalities in this area, and in particular low levels of serotonin. Now, serotonin is also really important in control of pain signaling, so it's no surprise that patients who have low mood or anxiety will also have abnormalities in the pain signaler. And the key thing is it's not the mood disorder that's causing the pain, it's the same process that's affecting serotonin levels is impacting on both mood and pain. And I think it's really important to address this misconception that antidepressants are sometimes prescribed. It's not because the clinician thinks the pain in your head, but it's trying to overcome this vicious circle of abnormal pain processing and that interplay with the road. In terms of other factors we might offer to deal with neuropathic pain, so things like licking pain patches we can use, I have to say the evidence base for them is a little bit mixed. And in very specific cases, we might do nerve blocks or infusions to manage neuropathic pain. But going back to this cross-sensitization idea, we know a lot of the patients will have the IBS type symptoms, bladder pain syndrome, increased nerve fibers in the uterus and musculoskeletal. So having a multidisciplinary input into managing all these things, I think is absolutely key. So for the bowel symptoms, our dietitian is incredibly helpful. Now I know there's been a specific webinar purely on nutrition, so I'm not going to spend a long time on this. But what I would say, there is no one specific diet that works for everyone with endometriosis, but different people will often have different dietary triggers. Now, for some people that might be gluten, someone else it could be lactose, other people it could be sugar, it could be alcohol, or it could be something completely unexpected like tomatoes or strawberries. And I think understanding one's own individual triggers can be really, really helpful, because then it allows you to do the dietary self-modification or with the support with a dietitian. I think equally that needs to be balanced by not having really, really restrictive diets where you're not getting all the important nutrients. And so I think often having support with a dietitian to try and work out what your individual triggers are, and then how to make sensible adjustments to your diet to then be able to try and reduce those triggers to your pain. Some patients have refractory symptoms, so ongoing symptoms despite dietary modification, in which case we might get the input of our gastroenterologist to advise whether or not sort of stool bulkers or lactose or other features might be important. And I think there's a huge amount that we don't know about the gut and the relationship to pain, as well as with endometriosis. And I think the more we sort of start to unpick the microbiome, so that balance of bacteria in our gut, I think in 5 years' time, what we're telling people to do with their diet and modification of the microbiome will be very different to what we're doing now. And I think it's a really, really interesting area. In terms of bladder symptoms, as well as dietary modifications, which can help with bladder symptoms, sometimes we use amitriptyline or cimetidine, and our urologists sometimes will offer installations of factors such as lidocaine or hyaluronic acid to help with those who've got very prominent bladder symptoms. I think in gynecology, often one of the other additional things we can add, if people have got coexisting heavy periods, that will contribute to the pain experience. So managing that effectively can be really important. And our physiotherapist, I think, is one of the most valuable people, part of our team. And part of that is, a lot of that is dealing with pelvic floor health and both laxity, but actually probably more commonly getting a lot of spasm and tightness in the pelvic floor, which can contribute to back pain, pelvic pain, as well as painful sex, which for many patients is really, really problematic. But people can also get abdominal wall trigger points. And so we've got a fantastic physiotherapist who works really hard with these women. But again, it's about individualising their care. And again, I know there's been a really good, either been or about to be a webinar on physiotherapy, so I'm not going to go into that much more here. But they are an incredibly important part of our team. And I realised I had a whole load of pretty animations to take you through the bits I was talking, so I'll skip on for that. But the other important part of our service is pelvic pain psychology. And as I said, we've got a psychologist as part of that joint assessment clinic, and they will then take patients on for further management from that appointment, but also within our pelvic pain team, we can refer directly to her. And a small portion of what she does is one-to-one management, but the majority of what she does is we run a living with pelvic pain group. So you may have heard about pain management groups or pain management programs, and they can be really effective. But I think there's a whole load of specifics to endometriosis and pelvic pain. I think particularly the impact on sexual function and a lot of the shame that's felt with a gynecological condition and any pain condition that can't be seen, but also how that impacts upon relationships, how that impacts upon fertility. And I think it's an incredibly isolating condition to have. And so that's where I think having a group of individuals all affected by women and those assigned female at birth with pelvic pain can be a really, really important thing. And of all the factors that are offered by our pelvic pain clinic, this is the one intervention that I think has the most long-term impact on people's quality of life and function. The aim of it is not about pain reduction, it's more about self-management to improve quality of life, although lots of the patients will report they've got improved pain control as part of going through the process. I think I would say that if people are still looking for further investigations, further interventions such as surgery, they usually tend not to access this. And we also wouldn't include people who've got mental health conditions that would prevent engagement, or they're already engaged in psychology-based treatment. I think it's really important with any kind of psychology support that you're not sort of shopping around and got multiple different people working on different aspects at the same time. That tends to make it a lot less effective. So as I said, our pain management group, so it's done every 2 weeks, over 7 sessions, and it's led by our psychologist, but we also have further input from our physiotherapist, our dietitian and specialist nurse. And a lot of it's about understanding pain, but then also giving people the self-management strategies to reduce the distress and improve their quality of life. And there's also quite a lot of focus on acceptance of pain and how to adjust your life to be able to enjoy it, do as much as achieve what you want to achieve. And I think one of the really important part of this is taking a compassion-focused approach. So this compassion-focused therapy has been developed to address shame and self-criticism. And I think, as I've said, living with persistent pelvic pain is really, really isolating and with a loss of identity. And this emotional impact is often associated with very prominent shame, stigma, self-criticism. And I think that can then affect upon our abilities to self-manage and adjust to living with pain. And there's evidence to suggest that this compassion-focused approach is certainly linked to reductions in pain catastrophization, improvements in psychological well-being, and reduced anxiety and depression, as well as engagement in self-management. And I think that's one of the reasons why this process is so effective at actually improving people's quality of life. So some of the other factors that we do is understanding those pain mechanisms that we've talked a little bit about today. So we've talked to education about neuropathic pain. And the second of these is this biopsychosocial model of pain, which I've mentioned before. So it's a way of understanding how our body, mind, and surroundings all contribute to how we feel and manage pain. And so as well as those biological factors that we've talked quite a lot about, there's the psychological factors, how our emotions and thoughts, so how we think and feel can influence our pain, and factors like stress and anxiety, and even our beliefs about pain can make it feel worse. And also some of our behaviours, which are often learned behaviours, so how we react to pain. And often I think sort of people start avoiding activities, and that also can then further make this sort of vicious cycle of pain getting worse. And I think also recognising the social factors, so the support from others and having family and friends who can help us better cope with pain, and some of those cultural influences, which can have both positive and negative impacts on both our pain experience and how we seek treatment, as well as economic status and access to healthcare and financial stability, which can also impact on how we manage pain. And I think a lot of the work that's been done by Endometriosis UK and others about engaging with the workplace to help support those with endometriosis to stay in the workplace, but to modify their practices to enable them to be able to function at work. Now, why is psychosocial psychomotor model important? Well, considering all these factors can lead to much more effective pain management and improved quality of life, and particularly a sense of empowerment. So patients become active participants in their treatment and using strategies that address not just their physical pain, but also their mental and social well-being. So in the pelvic pain group, as well as understanding these mechanism pains, we cover factors such as pacing, so that's sort of flying under the radar of pain and not using pain as a guide to our activities. And it's not just about the short-term gains in terms of reduced pain and fatigue, but also long-term that can lead to reducing that central sensitization we talked about earlier. I think pacing sometimes feels a bit difficult because of what it brings up, like, oh, I should be doing more than this. I used to be able to do this. What's the point? Feels good to get things done. But I think some of that awful boom and bust phenomenon, which lots of people will have, is much more negative in the long term. I think understanding and engaging our compassion is really important. And so this group being sort of non-judgmental, and also recognizing that it's not always easy. It's dealing with our own inner critics is a really hard thing to do, and often that's a more automatic response than the compassion part of us. But I think often learning to be most compassionate is thinking about, well, if someone else came to you with saying what you're feeling, how would you speak to them? And then learning to direct that compassion towards ourselves when we're struggling. Setting values and goals, which I think can help both when things are, when people feel stuck with their pain and keeping them moving forward, and then learning soothing factors. So planning soothing time, permission, seeing the value in it, so giving yourself time for you and supporting you. And then there is quite a large part of this is about intimate relationships, so both about communication, pacing, setting goals and agreeing limits with partners and reducing anxiety as well as anticipatory anxiety. And activating and practical aspects such as lubricants and pelvic floor exercise and occasion dilators. And a physiotherapist really helps with this. Again, I'm not going to reiterate what we're going to get covered in other webinars. I think one of the other factors people often ask about is complementary therapy. Now, we recognise we don't have all the answers. Now, certainly things like traditional Chinese medicine, acupuncture, there has been some evidence, and certainly dietary supplements such as turmeric and omega-3 have got really interesting preclinical and early phase data. I think we also recognise, though, that we don't have a good evidence base to recommend them to patients. But I think, again, this will be one of those things that will be slightly different in the next sort of 3 to 5 years about what we're saying about dietary supplements to manage endometriosis-associated pain. In terms of cannabis, now, we know anecdotally, both from what patients reported, I think particularly over the COVID pandemic, and also from survey data, that some patients are using this to help their symptoms. But I have real concerns around the use of cannabis in patients, both for the impact on mental health, impact on lung health, but also the adverse impacts on those in early pregnancy. But in terms of the cannabinoids, so these are the medications derived from the cannabis plant. I think actually, well, we know that there's quite a lot of really interesting preclinical data suggesting that these might have utility in endometriosis. And I think, taking away, those compounds that don't have all the adverse impacts on psychoactive components or impact on mental well-being, these might be really useful in the future. We don't have robust evidence for them at the moment, but there is lots of studies going on at the moment, particularly with CBD type medications, both in the US, South America, Australia, and we're starting one hopefully in the new year in Edinburgh, looking at CBD for endometriosis. But I think we also need to recognise at the moment, we can't say, I'm not going to recommend these because we don't have an evidence base for them. But again, it might be one of those things in 5 years' time that we're suggesting something slightly different. So I've talked quite a lot about us in Edinburgh. And I think it's important to reflect on what people can access naturally. And we know that people with endometriosis don't have full control of their symptoms, and it impacts upon quality of life. And the all-party parliamentary group report that was done in 2020, co-led by Endometriosis UK, surveyed over 10,000 patients with endometriosis and really, really highlighted how much people wanted to have access to psychological support, access to pelvic physiotherapy, and access to pain management. But we know that there are challenges in accessing them. And I think one of the tricky things for this is that there isn't necessarily huge evidence base to support pain management programs, specifically in endometriosis and pelvic pain. And then that inevitably leads on to what is commissioned by health boards to offer them as services, even though those of us who run pain management, pelvic pain management services know that it has, for the majority of our patients, it has a huge impact on their quality of life and well-being. So I think it's a really good thing that, as a lead on from the NICE guidelines, the NIHR, which is the big national funding body for research in the UK, has led out a specific commissioning calls. They've said they're going to fund research into this, specifically looking at pain management programs. And so those calls are out at the moment. So none of us know who's going to be the winning application to that. But I think it's really important it's done, and I hope that it is going to echo what we see in our clinical practice, that these processes are really effective. And I think that will lead to increased provision of these services for patients with endometriosis. We definitely want the access to these services. But what can you do till this happens? So every trust across the UK is different in what provision they have. What I would say is that every BSG centre has to have a named pain management specialist as part of the criteria to be a centre. Now, this might not necessarily be a specific pelvic pain service, but it still will be multidisciplinary pain management. And some people might not necessarily need a combined multidisciplinary approach, but just need input of specific members of that potential MDT. And so I think there are general pain clinics available, and it's very trust dependent whether or not you can get referred for primary care, or this needs to go through secondary care, so a gynecologist. Physiotherapy, again, very trust dependent, but there are pelvic health physiotherapists in every single trust. And I think particularly for painful sex, that is often can be allow referral from primary care for that. Dietitians and gastroenterology, GP and secondary care can both refer on to these. And I think for people who might be earlier on in their journey, there is a lot that can be done in primary care. And I hope I've reinforced that hormonal treatment might not take away every component of an individual's pain, but they often are an important part of someone's management. And I think it's all these small gains in different areas that all add up to good quality of life and function. So then one of the other factors of that is the neuromodulators, and GPs can prescribe these, although not all will feel comfortable doing this. And there are certain conditions or other medications where a little bit of caution needs to be had. And so that's the case, it would be more appropriate to refer on to a pain specialist first. Again, also people perhaps earlier on in their journey, or might, further surgery or even an initial operation might be the most appropriate thing for that. And that's something that can be accessed through secondary care. So through general gynecology should be able to offer that. And I think one of the other really important is giving people strategies to self-care for themselves. So I do think dietary modification is really helpful, and I tend to direct people to the NHS Inform website, particularly their IBS resources, which are usually very relevant in those with endometriosis. I think the isolation is really, really damaging with chronic pain, and I think that's where patient support organisations can be really helpful. But I think low impact exercise, pacing, mindfulness, all helpful strategies. And one of the other things I've not mentioned, but I think is an absolutely brilliant strategy, is having TENS machines. So these could be really helpful. And I think particularly because there are also quite a lot of discrete models out there. So it's something that people can have in the workplace when perhaps something like a hot water bottle might necessarily be the most appropriate thing. But a TENS machine can be much more discrete, and having those on, but after about 45 minutes or so, then that actually leads to the release of a whole load of your endogenous signaling chemicals that help suppress pain messages. So your endorphins, a bit like what you get when you go for a long run. So, sorry, I feel like I've been talking quite a lot. So just to finish up, pain is complicated. And I think sometimes we're quite fixated on the biological mechanisms, but I think it's really important to also acknowledge the impact of psychological and social factors on the pain experience. I also think it's very important that the biological component isn't usually one just thing. There's often multiple different factors. So there's the inflammation from endometriosis, the scarring both from the disease itself and from surgery, but also that cross-sensitization is really important. So the bowel and bladder irritation, as well as neuropathic pain, which I think is hugely important in pain management for endometriosis. Now, for many people, our sort of first, second line treatments with hormones and surgeries can be effective, but I think particularly when those have been ineffective, multidisciplinary pain management can be really, really important to give added benefit, improve quality of life when symptom control is incomplete. But equally, it does need to be very individualized, and there is no one size that fits all, but also for a single individual, their needs will change at different points and across the life course. And often it's not one signal treatment, it's lots of different approaches in parallel. So the dietary modification, a bit of hormonal suppression for cyclical symptoms, addressing the neuropathic component, and then some of that psychological strategies, all adds up to better control of symptoms and quality of life. I do think multidisciplinary care can be hugely effective. I wish it was better available to everyone, so actually people could access this much earlier on in their pain journey rather than it often being the reserve of those who failed other treatments. But I hope that with increasing evidence that provision of this will increase to enable people to access effective pain management from an early stage. So I'm just going to finish up by thanking, I work with a huge team at Edinburgh, both clinically and research, as well as their funders. And I'm happy to take any questions. And that at the bottom is the link to our pelvic pain web pages as part of our more generalized expect web pages. Thank you very much.
Thank you so much, Lucy.
Sharing.
Brilliant. What I'll do is I'll take a few live questions. We've had a few coming in during the chat during your webinar. So we've got one from someone here saying, what nerve blockers would you consider and what would be your criteria in getting on those nerve blockers?
So I find most of the people I see, not just in my pain clinic, but in my endometriosis clinic, have got a neuropathic component to their pain. And a lot of the hallmarks of that is people having a burning, shooting, stabbing criteria to their pain. I do tend to do a bit of sensory testing, looking for altered sensation to cold, light touch, and sort of to a blunt needle to kind of demonstrate that there are sensory changes. But usually from the history, it's fairly clear people have got a neuropathic component. Often the drug that people are started on in particular, maybe more so in primary care, is amitriptyline because it's got some evidence for IBS and bladder pain syndrome. I find, because it's quite sedating, a lot of the people I see don't really like it. They find they've got sort of almost a bit of a hangover feeling from the next day. Now, if people have got terrible sleep, they like the fact that amitriptyline makes them feel a bit sleepy, and so that can improve their sleep quality. But most people I see hate that component, and it means that they really struggle to get on a reasonable dose of it just because of the side effects too much. So the one I use an awful lot of is nortriptyline, which is the same class of drugs, but it doesn't have that sedating effect. And the other one I use quite a lot of is duloxetine. I don't tend to use the gabapentinoids very much, partly because they've got more side effects, and also they can sometimes be associated with weight gain, and they can sometimes have an adverse impact on mental health. So I don't use them very much, but we've got a really interesting bit of work which is about to come out in a couple of weeks' time, so I'm going to work out how much I'm allowed to say about it. But some of you might be aware that a few years ago in Edinburgh we did a really big, or led from Edinburgh, a really big trial called the GAP2 trial, and that was looking at gabapentin for pelvic pain. So this was specifically in patients who didn't have endometriosis, so they have normal laparoscopy, and that trial showed very conclusively that gabapentin didn't work and probably had more side effects. So a lot of people have moved away from gabapentin, but we've gone back to that data, and I was quite surprised at the outcomes of that trial because I'd seen quite a lot of people at the end of it who'd absolutely worked for. So we went back and looked at the people's DNA who'd taken part in that study, and there's a gene that part of a gene that seems to predict who responds to gabapentin and who doesn't. So what I'm hoping is that we'll be able to essentially go back and do that study again. And actually, I don't want to do it in just people who've got normal laparoscopies. I want to do it in people with endometriosis and those who've got suspected endometriosis, and then look at people's genetics and then decide if you go into the trial or not. So that might actually open up us using gabapentin again, but I think it'll be in a much tighter group and only giving it to the people who we think are going to respond to it. Sorry, that's a slightly longer answer than you expected. I probably shouldn't say much more of that, but I think on the 15th of July, you can all find out much more about what's actually in that study.
We'll be waiting with open ears. We've got one here from Christiane. She said it's so encouraging to hear about a multidisciplinary team approach. However, when we talk about social factors and neuropathic pain and introduce a psychologist, it feels triggering because often we're made to feel that the pain is in our head. So she's asking, how can we encourage women to be more open to this approach, and more importantly, ask for this type of help if it isn't offered as a matter of course?
Yeah, and I think that's why I sort of tried to spend a bit of time about saying about the sort of this really complicated space between mental well-being, pain, and I think it's also really challenging because patients with endometriosis have almost invariably had a really long journey to getting a diagnosis. They've often felt very dismissed, and I think the piece of work that Endometriosis UK released earlier this year, I found that really upsetting. I mean, I think it was, up in the 70%, high percentage of patients felt dismissed by clinicians. And I thought we were better than that now. I thought that those were sort of the bad old days from kind of 10 years ago where people didn't know about endometriosis, they didn't investigate them. We've now got really clear guidelines about who should be referred on. And so I think it's really sad that that message doesn't seem to be getting through. But I think we all need to recognise that having a chronic pain condition will inevitably usually have an impact on mental health, and also that sometimes there are biological factors that make people more vulnerable both to developing a chronic pain condition and also developing low mood or depression. So I think it's about, we should all be talking about mental health much more, and I think the work that Endometriosis UK does in terms of trying to raise the profile and the importance of this is hopefully going to start making changes. But I think also now is a good time in that we've got a women's health strategy, a women's health plan in Scotland, we've got women's health champions, and I think everyone is beginning to talk more and more about the importance of mental health, and then trying to have this joined up approach. I think whilst we try and address these problems in our silos, and the gynecologist has been really focused just on the hormones and the surgery and the bleeding, and then if you've been sent to a gastroenterologist, you'll get really focused on the gut. It's having this joined up approach is really important.
Yeah, brilliant. Thank you so much. Shelley Ann has asked, you've mentioned living with a pelvic pain programme. She's just interested in sort of how long a programme like that would last and what would it entail. I think that was your group programme you're mentioning, which sounded fantastic.
So I was sort of keen not to say, oh look, we've got this fancy clinic in Edinburgh. There are other, I know there are other trusts that do specific pelvic pain management programs. Our setup in Edinburgh is it's 7 2.5-hour sessions, which I know does make it tricky for people who are in full-time work. But we usually will, if they need, then provide them with documentation to take to their employers so that allow them to access it. It used to be purely led by a psychologist, but now we have specific sessions by a physiotherapist, or dietitian, or nurse specialist. And we do a mixture of online and in-person programs, so that there might be some that are completely online and some that are completely in person, and it just sort of depends which time of year, when people can access. But it is a time commitment. But I think that's also because these things you can't just get all the right answers in a kind of 1-hour session. And a lot of this is also, it's not just about being aware of the changes, but then implementing it. And so giving people that support to help reinforce starting to make those changes in multiple different areas of life, which it's hard. It's really hard to make change. It's easy to kind of say, right, I'm going to do something and then keep it up for 2 weeks or 3 weeks, and then everything starts drifting by. So having that program over several months, I think helps people to make that consistent and maintain change in their life.
Thank you. And we've got someone asking questions about GnRH injections. So they're asking, can irritated nerves and any new ones created become desensitized while someone is on the GnRH injections? So much so that they might not suffer as much pain after coming off the injections.
So I think there's sort of a multitude of different ways that it works. So the GnRH agonists or antagonists, sorry, that's a terrible sentence, isn't it?
It's hard.
So there's a tablet called a GnRH antagonist, and then it's injections that are agonists. They basically both work in the same way, put people into a medical menopause. And because endometriosis is predominantly driven by estrogen, by completely suppressing the estrogen down, the endometriosis becomes much less active. So you've not got as much inflammation, so causing all that irritation to the nerve fibers. But also, if we can dampen down people's pain stimulus, it allows over time then the brain to start resetting back to more normal processing. So that's why it can also help, particularly sort of essential, well, both peripheral and sensitization a bit. And it's mainly by reducing all that stimulus that it's getting. The problem with these medications that when people come off them, the endometriosis often, it's not gone away. It's really suppressed, but it does tend to then start to creep up again over time. So now with different people, that will happen at different speeds. But often we do find symptoms come back. But it gives people a break where you can then also give them a neuromodulator as well to try and dampen down that central sensitization.
Brilliant, thank you. I think we've got time for one last question before we wrap up. So we've got one from Kat, who's asked, do you have any particular pain management strategies that you might recommend for someone who's been through menopause?
Well, I think all the pain management strategies are applicable for both people, both pre and post-menopause, apart from the hormonal treatments. So in terms of the self-management strategies, I am a massive fan of dietary modification. As I said, there isn't a one size fits all, but trying to find what your own individual triggers are. I think low impact exercise, there is some good evidence for yoga and endometriosis. And I think some of that's about the kind of time for yourself, activating those soothing pathways, but also by stretching, and that can help with some of the trigger points. And I think also when we've got stronger cores, that also makes us slightly less vulnerable to some of the musculoskeletal components of a chronic pain. I think there's also that part of it being something that you're doing time for yourself is really important. And then paracetamol, ibuprofen, as I said, I do try and get everyone off opiates. I think they're really bad things in the long term. And then a TENS machine. TENS machines are great. The really cheap ones on Amazon, you don't need a fancy one. I think they can be really helpful. And particularly now you can get ones that are rechargeable, so you don't need to worry about all the batteries in the environment. I've probably missed something else up there that I think is really important, but pacing is really important, mindfulness.
Brilliant, thank you so much. I think that sort of concludes our webinar for tonight and the time we have for answering questions. I just want to say a massive thank you to you, Lucy. I thought the webinar was brilliant, and we've already had a few comments in the Q&A just thanking you and thanking and saying how amazing it was.